On this slide, we'll discuss the SGA baby, or small for gestational age, and the premature infant, both of which would have low birth weights. For a small for gestational age baby, this means that the weight is less than the 10th percentile for gestational age on the little chart that you would plot their weight. The most common reasons for a small gestational age newborn is maternal hypertension, poor maternal nutrition, drug use and abuse, heavy smoking, alcohol consumption, and having multiples. One example of the multiples is having maybe twin-to-twin transfusion syndrome, with one twin doesn't get as much nutrition as the other twin, so one of the twins would be born smaller than the other. For assessment findings, you'll often see that they have a large head in proportion to the rest of their body. They're thin, their extremities will be thin, and their trunk will be thin. They'll have a thin and a very tiny umbilical cord. The main risk factors for this group is low blood sugar and hypothermia. So those are going to be our nursing interventions, is to check blood sugars and to prevent heat loss in this baby. We want to teach mom how to keep the baby warm. We want frequent feeding, so encourage feedings, and then the physician will decide whether or not the baby needs higher calorie level formulas. So for the hypothermia, we want to also watch for respiratory distress, because those two things are related together. So our goals for the SGA baby: monitor blood sugar, monitor temperature, encourage feeding, watch for poor feeding, watch for respiratory distress, and do daily weights and make sure you check vital signs. For the preterm baby, the premature baby, that's a baby born less than 37 and 0 weeks gestation. There is extreme prematurity that's less than 28 weeks, and then there's different classifications for the younger and younger ones. About the smallest that can stay alive in this time right now is about 23 weeks gestation. And the higher the birth weight, the better. But these babies will often have very low birth weights. These babies look slightly different than just the small for gestational age baby. The small for gestational age just means that they're smaller than their peers that are born in the same week's gestation. For premature, though, we will often see skin that is thin with visible arteries and veins, very fragile and shiny skin, lots of lanugo. Their ears are very, very thin and flimsy. You can often see like their rib cage pretty easily. Their creases on their feet are not as much as a term baby. But let's look at the complications of the preterm newborn, and they're very similar to the SGA. But one of the main problems is respiratory function is not going to be term. So we're going to have breathing problems, and apnea is the most common, and that's when the baby does not take a breath for more than 20 seconds. What the nurse can do when this happens, of course, we can stimulate the baby to breathe by tapping on the bottom of the feet. They do have extreme difficulty with thermoregulation and temperature control, so they'll be in a incubator with a controlled isolate temperature on there. They often may have heart problems, not necessarily heart problems, but they're born with a PDA, a patent ductus arteriosus, where the lay people call that a hole in the heart, because it's not the baby's not quite old enough for that hole to close. So it may cause some oxygen exchange problems. So they'll be on the monitor, definitely. They're more at risk for intraventricular hemorrhage or brain bleed. So we handle the premature baby very carefully that we don't do anything to stimulate a bleed in that brain. They're very fragile. They are at risk for what we call NEC, which is necrotizing enterocolitis, which is a severe GI infection. So they're way more at risk for infections than the term newborn. They often have anemia and jaundice. Their liver is definitely not mature enough to get rid of that extra bilirubin. So we need that. Billy lights are usually common to use, the phototherapy in premature babies. And then they are so small that they have fluid and electrolyte imbalances that could happen. So we just monitor their vital signs and they do a strict INO on these babies. Premature babies are very sensitive to oxygen. So a condition that can happen because of too much oxygen or just from being preterm is called retinopathy of prematurity, also abbreviated ROP. So in order to help prevent this, the nurse will use the least amount of oxygen necessary, and sometimes they'll lower the limits for oxygen use orders to like 95%. So maybe enough oxygen to keep the baby's O2 levels 95%, and that will help decrease blindness in the baby's eyes. Cerebral palsy is also a problem that happens during birth from being hypoxic, and since we have the respiratory issues, they may have periods of hypoxia, which can lead to hypoxemia, and which will also lead to brain development problems or brain damage. So cerebral palsy lines up with the brain damage from hypoxia issues, also called HIE if you want to research that or watch the video on YouTube that I put up. Premature babies often have developmental milestone delays, learning disabilities, and other behavioral psychological problems. So these are things that they'll do follow-up visits to watch for these things. So for the premature baby, it's very similar in things we might see: low blood sugars, low body temperatures, but at the same time for the premature infant, we want to prevent injury. So we want to be very careful with their body and their skin and their heads. So we want to prevent hemorrhage. We want to watch for signs of a hemorrhage, which would be your increased intracranial pressure signs. And so we want to do respiratory support for the premature baby, but be careful with the oxygen. Don't want to cause ROP. And monitor temperature, weight gain. These babies will need 22 to 24 calorie formulas. Breast milk is better, and then they can be fortified with an extra powder in the breast milk to make the 22 or 24 calorie nutritional plan. And then education for parents when the baby goes home, if they had to go on an apnea monitor or those type of things. On the other end of the spectrum, we have the LGA baby, or large for gestational age, and the postterm newborn, which is greater than 42 weeks gestation. The LGA baby means that the baby is over the 90th percentile for their gestational age. The most common reason for this is maternal diabetes, which makes big babies. It can cause delivery issues like shoulder dystocia, and oftentimes they're delivered by C-section. They may have a fracture of the clavicle during difficult deliveries, or they may have meconium aspiration, because oftentimes the LGA baby has made a meconium stool in the wound, whether it's related to difficult delivery or from being closer to term. The large baby is at risk for hypoglycemia, so we should make sure we check blood sugars and also monitor for respiratory distress, because those two things are related together. Respiratory distress may also be present if the delivery was difficult. For the assessment findings for a large baby, you will see that they are quite large compared to the others. Usually they're over 8.5 pounds, and they may be listless or apathetic, meaning they just kind of move slow. Assess this baby for birth injuries and monitor for tremors or signs and symptoms of hypoglycemia. Make sure the baby has frequent feedings and monitor their respiratory status. Don't confuse postterm with LGA, because postterm means that the baby's just born past 42 weeks, but often these postterm babies can be smaller for their gestational age, because after a while the placenta becomes inadequate and they start to have a low nutritional and oxygen exchange from the placenta. These assessment findings for the postterm baby are mainly skin conditions. So they are really alert after birth. They have decreased subcutaneous fat, looser skin, dry and peeling skin, very little to no vernix or lanugo, very long nails. They also may have meconium staining of the umbilical cord, and it's quite common to have meconium stained or meconium stool before delivery for the postterm, post-dates baby. So we will be monitoring for signs and symptoms of meconium aspiration and infection. Low blood sugar is also a risk factor here. Let's look at neonatal jaundice. also called hyperbilirubinemia. There are two types of jaundice. The first one is physiologic jaundice, which is a normal occurrence in the newborn period, or pathologic jaundice, which is a serum bilirubin level that rises excessively, and this can actually cause neurotoxicity and connectors, and we'll talk about those in just a second. In the newborn, we notice jaundice when the bilirubin levels reach 5 to 6 milligrams per deciliter. It first begins to appear on the face, and then the sclera may be tinted yellow, and we can check for jaundice on the skin if we press on the tip of the nose, and it will blanch, and then you let go, and the blanched, it looks yellow. Lab work will need to be conducted in order to see what level the jaundice is, and then it's compared with a chart that lets providers know when they should start phototherapy. So who is at risk for jaundice? The premature infant. If there's blood type incompatibilities, that's your Rh negative mom and Rh positive baby. A lack of effective breastfeeding, so they're not getting enough nutrition in order to excrete the bile of the bilirubin through the urine and feces. Excessive bruising on the baby, like a brain bleed or lots of bruising on the face from a delivery, those things can increase the risk that jaundice will develop in the newborn. So what do we do about jaundice in the newborn? Well, we will encourage frequent feeding if it's not contraindicated to whatever's going on with the infant. So frequent feeding, breastfeeding, formula feeding, because we want the baby to poop. The more stool that comes out, the more bilirubin that comes out too. So monitor for stool production, weigh diapers. We want to make sure the baby has adequate intake and output. If they're going to have phototherapy, we will put patches over the eyes to cover their eyes and protect them. We will expose all the skin except for the genital area, because they have to have a diaper on, to the light source. And we will monitor their behavior because they don't really like to be unwrapped in an isolette, and then also their body temperature. And that's often why they put in an isolette with the phototherapy lights to help maintain that temperature control. Sometimes they're just put underneath the warmer, or sometimes they're just in their bassinet uncovered, because the lights can produce a little bit of heat, but not a lot. Now, we definitely want to make sure that the bilirubin levels do not get into a dangerous level. The word connectors is extremely high bilirubin levels that will actually begin to cause brain damage if it's not controlled. And those are usually the result of the blood incompatibility problems with jaundice.